All right, well, welcome. We're so glad that you're here. So hopefully the timing lined up that you're either early in your first trimester or you just experienced a positive pregnancy test, because we're going to be talking about all the high points to go ahead and have a successful pregnancy. So kind of just going through an overview of our topics for today. We're going to be discussing everything that's listed here, which is a pretty comprehensive list, but like Allison mentioned, we will absolutely leave time for questions. So first, we would just want to say congratulations. Like many women out there, I'm sure once you get one positive pregnancy test, you take 3 or 4 because it's just, you need that reassurance, you need that confidence that it's real and it's all happening. And so that is super common. But if you're having your first baby, you might be wondering, gosh, like what are the next steps from here? And so we can kind of move on into, first, you need to figure out kind of who you will seek care with in order to continue your pregnancy.
Through IHA, the providers that you can seek prenatal care with are the obstetricians and gynecologists, and then there's certified nurse midwifery services. Typically, that's something that women will think about as soon as they find out that they're pregnant. They're like, okay, what's the next step? What do I do? What can I do? What can I do? I'm an established care. And so by doing that, then you're going to start that plan of beginning prenatal care. And we know that prenatal care is one of the best things that we can do to start a healthy pregnancy. It can ID early health issues or challenges that might be individual to yourself. It helps you to build a trusting relationship with your provider so that if emergencies arise or when it's time for a delivery, you are trusting your provider that you're seeing. And then it provides an ongoing assessment of you and your baby. And we know that by having prenatal care early on, you're going to improve health outcomes for you, yourself, and your baby. With a new OB visit, you should plan for a physical exam. You're going to also plan to review your past medical history, surgical history, current medications and vitamins, establishing a due date, labs and genetic screening, if it's something that you're interested in, nutrition, weight gain, exercise, vaccines, individually specific recommendations. We always talk about at typically a new OB visit, interpersonal violence, drug use, cigarette use, alcohol use, and those are typically what you would have happen at that first visit.
A lot of those might sound familiar because they were also covered in the outline. So we're going to delve deeper into each of that lists.
So usually women are also very interested in like choosing a prenatal vitamin and does it matter and which one should I take? And sometimes, we see based on internet, what's the latest and greatest thing to take. It's really hard with vitamins. You just need to take one daily. You wouldn't want to take out any extra additional vitamins because some vitamins can be toxic at higher doses, such as vitamin A. There is a website that can help you kind of like get through some of like which one should I take. It's called labdoor.com. A patient of mine actually taught me about this. They independently test supplements and then publish the results. So say for instance, you're taking the Nature Made prenatal multivitamin, you can look that up there. They're going to give a grade to that vitamin. And it's basically going to say like, does this vitamin actually say that it has in it what it's supposed to have in it? And that can be helpful for patients. It's not always going to be your most expensive vitamin that's going to be the best one. We actually prescribe vitamins too through Meijer often because Meijer does give free prenatal vitamins to women.
Which is a huge advantage, but it will be like a horse pill capsule. And so we prefer you take the horse pill because it has better absorption for the vitamins that we are trying to help to nurture a healthy pregnancy, but just a forewarning, we can't get free gummies.
Yeah. And so in your prenatal vitamin, we want to make sure that there's key ingredients, and that's where it might be different than a regular multivitamin. We want to make sure that you're getting enough folic acid. We know that by getting enough folic acid, that's going to decrease the chance of neural tube defects. Actually, all women of childbearing age should be taking a prenatal vitamin. just in case someone becomes pregnant without having planned a pregnancy. And we know that almost 50% of all pregnancies are not planned. So taking a prenatal vitamin during those childbearing years can be a good healthy start.
And on par with the folic acid, actually the impact in pregnancy for the neural tube is actually between 3 and 4 weeks before most women recognize that they are pregnant. So it is great if you are already taking it. And I think that's listed here, the specific milligrams.
Yeah. And then also calcium and iron, all the vitamins and minerals that you need to like maintain healthy pregnancy that also help to kind of ward off some issues that can come up later in pregnancy, even with like tissue healing, you know, if you're thinking about closer to delivery, even mood, your vitamins and minerals can be helpful with.
Especially those of us living in the northern climates where we don't get a lot of vitamin D.
Right.
So we do have some supplementation in our prenatals. And then when we were discussing all of the past medical history we would review, this is also another reason why the earlier that you get involved with prenatal care, the better, because if you are on any home medications, we would want to review those with you and make sure that they're safe for pregnancy. And so common medications that we frequently require management throughout pregnancy and would want to be optimized are medications for blood pressure if you have diabetes outside of pregnancy, any thyroid issues, because that will, as pregnancy evolves, likely require dose adjustments, and then mood disorders. And so with that being said, if you are on medications, we will assess whether it is safe to continue those or if there is a better alternative at that first visit. And if you came for our preconception, hopefully that's already been kind of discussed. So I do want to just take a minute to talk specifically about mood disorders in pregnancy. And so that kind of encompasses anxiety, depression, which approximately 30% of all women do experience, whether that is with their first baby or after their first baby in terms of postpartum. I find as a provider that most primary care doctors or psychiatrists have less comfort in pregnancy about continuing women on these medications. So I think I want to reassure you that if you are taking a mood medication, whether that be, Zoloft, Prozac, Wellbutrin, Lexapro, it is actually safer and recommended by ACOG that you remain on that medication. And that is supported by a lot of data that if your mental health is optimized, changing the medication leads to instability and can lead to worse outcomes, such as increased self-harm, increased rates of substance abuse. So any medication that you've been taking, I would say the first step is usually not to completely discontinue. And if other providers have told you that you should discontinue that, I would definitely talk with your provider specific to your obstetric care before feeling like that's the only option.
Kind of coming off that too, with substance use and pregnancy, in your history we review, do you have any history of tobacco, alcohol, marijuana, illegal drugs, prescription drugs taken for non-medical reasons. We know that taking things during pregnancy can cause birth defects, low birth weight, preterm birth, and actually stillbirth as well. Talking about substance use throughout pregnancy, it's not probably going to come up just once in the pregnancy. It may come up every trimester, and depending on history, it could actually be even at every visit. It's something that is modifiable. We know that typically when women find out they're pregnant, they're wanting to be as healthy as possible, but we also know that can be challenging with substance use. And so we do have additional support and resources, and we would prefer if our patients open up about that so that we can try to help them have a safe pregnancy. With alcohol too, there's no scientific record of a universally acceptable and safe level of alcohol exposure in pregnancy. And that's something that usually comes up and is asked, well, could I do this? Could I do this? Oftentimes if you're planning a pregnancy, we request for women not to use any substances or alcohol. But most of the time women do find out they're pregnant, maybe unexpectedly, and then worry about that. If you find out you're pregnant, then we just ask that you stop any substance use at that time. At that first visit too, we're gonna establish a due date for you. Most of the time, your due date can be calculated from your last menstrual period, unless you have irregular cycles. You can expect a pelvic exam and an ultrasound at your first visit. We know that an ultrasound should be consistent with your period dating to determine your due date. That's not always the case though. And so we know that like in that first trimester, it's going to be more accurate if they do match, and if they don't, then we talk to you about, are we going to change that due date or not? Typically in the second and third trimester, we're less likely to change the due date. One other thing too is like during your ultrasound, if you're, early on, we're often not going to be listening to the heartbeat. We're just going to be visualizing that heartbeat. And then each of your visits that you come to after that first visit, we're going to try to listen with a little Doppler machine. So establishing a due date too, I mean, that's really kind of one of the things. As soon as you take that pregnancy test, it's like, oh my gosh, when was my period? And so something that women have been doing, is you can either do something called Nagel's rule, where you're subtracting 3 months from the first day of your last menstrual period, add 7 days to that, and then add 1 year. So for instance, if your last period was October 6th, you would subtract 3 months. And that would be July 6th. And so then you would add 7 days, and your due date would be next year on July 13th.
There's also a million Google calculators that will do it for you. So most of the time when people come in for that first visit, we are not surprised if you've already gotten that date. And if you have a date, I'm happy to just ensure that that's consistent with what you were thinking.
Yeah. And then to like trying to get into an appointment in your first trimester is ultimately the best. Second and third trimester ultrasound dating can be less accurate. Something else we may ask you, especially if your periods are irregular, is about maybe like if you have a sure date of conception, that can be helpful. With ultrasounds too, I think it always comes up. I mean, everybody wants to be able to see their baby. Am I going to have another ultrasound? When am I going to find out the gender? And what we always want to let people know is we do recommend another additional ultrasound in the second trimester. It's an anatomy scan. And what the goal of that is for us is really to like look at all of the structures of the mom, looking at your uterus, looking at your ovaries, looking at the baby, the brain, the spine, all of the anatomy, where your placenta location is at. And then that's also when you can find out the gender of your baby. The other thing is we may have additional ultrasounds in the pregnancy, depending on different risks that some women may have. So for instance, women that have been diagnosed with COVID in pregnancy, we are doing a growth ultrasound in the pregnancy, just to make sure that the placenta has not been affected. And that's also like gestational diabetes, hypertension, growth restriction, if there's complications maybe with where your placenta is located. I mean, those are times that we're going to have another ultrasound. And then typically around 36 weeks, we'll also scan too, just to make sure that that baby's head is down. And if that hasn't happened, when you come into triage or labor delivery, we're going to do a scan then too, just to check where your baby's at.
All right, so we're going to delve into some specifics about genetic testing. I think this is a really trendy topic that you even might be hearing about on the internet or in advertisements, because there's a lot of direct consumer marketing about genetic testing. And so just to bring it down to face value, genetic testing is going to help to assign whether you're someone who is low risk or high risk for specific genetic syndromes or congenital anomalies. And so when we think about genetic testing, typically our tests are designed specifically to look for Down syndrome, trisomy 13, trisomy 18, and then certain sex chromosome disorders. And so those are the new trendy tests, which are often referred to also as cell-free DNA or NIPT, which is referred to here on the slide. And so When we think about screening tests, remember, this is not going to tell you a definitive yes or no answer. I heard the analogy once that it kind of either turns the light on or off. So it assigns like, are you low risk or high risk? But if you get a positive result, it doesn't mean that necessarily that that's a true answer. And so when people come to me and I bring up genetic testing, some people think right away that I am referring specifically to the needle in the belly test, which is also listed here on the slide. That's called an amniocentesis. And so this slide is really nicely broken up into the screening test on the left side and the diagnostic tests, which are on the right. And so if you get a positive screening test, which are usually just blood tests or ultrasounds, then sometimes we would go ahead and recommend additional testing with a diagnostic test. And that will tell you what is the chromosomal or genetic makeup of your baby. And so most women who are doing genetic testing at this point are electing for the cell-free DNA test. And that is because it's actually the most accurate. And like I mentioned previously, it just requires a blood draw. That has a convenience factor. It's not invasive for you, but also that is a nice way to find out the gender as early as 10 weeks. So in order to perform the test, there has to be enough of baby's blood circulating in, or baby's DNA circulating in your blood to get an accurate result. So we have kind of a relationship with the company so that it won't cost too much out of pocket to you. But if you're solely seeking to know the gender, I do think there are better ways to do that. And there is like a cheek swab test you can order on Amazon, which is much cheaper than doing the genetic test just to find out the gender. And so in terms of other types of genetic testing, previously cell-free DNA is much newer. In the past 5 to 10 years, it's really evolved tremendously. But before, we were still using genetic testing, and one way to do that is an early ultrasound. And so between 11 and 14 weeks, we can look at the thickness of the back of the baby's neck on ultrasound and almost do kind of a first trimester anatomy scan to assign specifically a risk for Down syndrome. And that is sometimes paired with blood work that we measure serum hormones that are related to the pregnancy to assign a risk. There were other tests that you also might have heard of, like a quad screen, and that is a blood test exclusively that looks at hormones from the placenta that then assigns a risk for Down syndrome and trisomy 18. Again, if your screening test comes back negative, there's no further testing that needs to be done. And then if it's positive, sometimes we would offer diagnostic testing with one of those more invasive methods, but that's not something that's mandatory. And so when we think about the two questions on the screen, who should have it? We actually offer it to all women. However, that being said, I usually tell women who are younger in their 20s or early 30s that overall your risk is low. And then as you age, your incidence of chromosomal abnormalities increases. And so we do often encourage genetic testing, especially after 35. When we think about what the goals of genetic testing are, I typically lay that out for patients that there's kind of two ways or schemes of thinking. And so some women prefer to just have as much information as possible or would like early reassurance right away at the beginning of the pregnancy. And so certainly if that's someone that sounds like you, then absolutely we can do it. And then the other reason to do it would be if you were going to change the outcome of the pregnancy. And so I know this has been a hot topic in the press, but if you're someone who would consider termination for a genetic abnormality, then we should do genetic testing early on because obviously those procedures are much less invasive as at earlier gestational ages. So specifically, understanding genetic disorders is complex. We are all made up of genes and chromosomes, of which we should have 46. And anytime someone has extra genetic material, that's referred to as aneuploidy. And so that's kind of what we're looking for when we're doing genetic testing. We also will discuss with you something called carrier screening, and sometimes you may have been offered this at a previous preconception visit, and that is actually looking at your genetic makeup. So when we think about carrier screening, that is related to whether you are unaffected by these disorders, some of which are listed there, but you carry the gene that you could potentially pass on to your baby. And these types of diseases often require 2 copies of the gene in order to be affected. So if you screen positive for one of these disorders, then we would recommend that your partner be tested. But if you screen negative, there's no way that your baby could potentially be impacted. And when we offer this, previously we really were using ethnicity-based testing, but of course, if you're someone, again, who wants as many options as possible, there are larger expanded carrier panels to look at your genetic makeup to see, is there a possibility that you could pass on a gene to your baby? And so some of the things that are mentioned here, sickle cell, I would say cystic fibrosis is the most common in the Caucasian population. So about 1 in 20 women are carriers for that gene, even though most of us are not affected, remember. And then Tay-Sachs, and if you're specifically Ashkenazi Jewish population, then those incidences of carrier diseases are much higher. So it would be important to talk to your provider about your background, and if you know anyone in your family who does have Fanconi anemia, thalassemias, Niemann-Pick, just to name a few other ones that aren't listed here. And so I mentioned this briefly, but really genetic testing is optional. It is really related to what your and your partner's beliefs are and thinking about what you would do with that information. I always tell patients at the first visit that even if you elect not to do genetic testing, as providers, that ultrasound that Nicole talked about, the anatomy scan at 20 weeks, is still a form of genetic screening. And so during that ultrasound, they're looking at all the brain structures, the 4 chambers of the heart, head, neck, lungs, brain, kidney, making sure all the organs look normal, and then they measure all the bones. And so in genetic disorders, usually there are associated ultrasound findings. And so it's not that you're going to get no information or no screening. That is just done a little bit later in pregnancy.
And changing gears to nutrition for healthy pregnancy. If you are pregnant with 1 fetus, it's important to keep in mind that you really only need about an extra 340 calories a day starting in the 2nd trimester and a little bit more in the 3rd trimester. There's a lot of emotion surrounding nutrition. And so again, during pregnancy, this is a time where women are often thinking like, I really want to try to be healthy. Something to think about is you want to not eat for 2. It's often going to be something that other people will say to you and comment on, like, oh, you need to eat a lot more, you're eating for 2, and that's not actually necessarily true or healthy for you. So keep that in mind. In the 1st trimester, you really don't need any additional calories, which is a good thing because usually in the 1st trimester, women don't feel that great and aren't eating very much. And that is always something that they're worried about. Am I also starving my baby if I'm not able to eat? And that is not what happens. With nutrition, I always just like to tell patients, like, eat the rainbow, like eat as many colors of foods. You want to hydrate with water. You really don't need to drink additional juices at all. I mean, they're empty calories. You get some vitamins from that, but really you're going to get your vitamins through your prenatal vitamin, but also through your nutrition. So just drinking water. All of the different food groups, fruits, vegetables, whole grains, nuts, beans, seafood, vegetable oils, limiting caffeine intake. That's usually something that comes up pretty frequently too, where women are like, oh my gosh, can I have my cup of coffee in the morning? Yeah, limit it to 150 to 300 milligrams a day.
Which is not a venti Starbucks. I always tell people because those can hide a lot of caffeine.
Yes. And you can actually look up all of those drinks to see what the caffeine is in milligrams. And also too, like even if you're a tea drinker, it's usually listed on the box. And other foods have caffeine in it too, like chocolate. So keep that in mind. You want to avoid added sugars in your nutrition. You want to have also avoiding refined grains, and then, a lot of fatty red, and then also processed meats. Related to nutrition, some women will crave non-food items, and this can be based on a nutrition deficit. Some examples would be like laundry soap or baking soda or clay, and this is called pica. So if you do find that you are craving non-food items, this is something for sure to talk with one of us about. because we would do some additional blood testing just to see, like, are you anemic at this time? Just because we don't want you getting rid of regular nutrition to eat things that are non-food. Another thing related to nutrition that women will often ask, it comes up, we want you to see your dentist regularly for cleanings and checkups. That was probably something from 25 to 30 years ago where people thought, oh my gosh, I can't go to the dentist when I'm pregnant, and that's not actually true.
And then depending on what your work environment is, it's also a good idea to just kind of be more mindful about the things that you are around specifically. And these things might not even cross your mind as potentially harmful, but could have impacts on the pregnancy. The first component listed here is plastics, and we all in our commercialized world that we live in this affluent nation are constant consumers of plastic, but unfortunately our bodies don't have a very efficient way of clearing plastic, and that often is expressed in breast milk. So just being mindful, if you can avoid it and use reusable containers or glass, that is going to decrease the amount of any of those plastic run-ons into your body. Fertilizers, lead paint, again, hopefully most of you are not working in these types of environments, but asbestos and then mercury comes into play, of course, when we're thinking about specifically fish. So eating fish is actually great and healthy in pregnancy. I usually tell women there is a few good fish, and usually the ones that are things to avoid are probably not those that are familiar to you or common in the United States. So the king mackerel, swordfish, these are going to be larger fish that maintain more mercury, but the things that you commonly get in restaurants and at the grocery store, shrimp, any tilapia, salmon, tuna, those are very healthy for you. And so we recommend 1 serving of 4 ounces of fish, and you can do that up to 2 times per week. And that is also going to give you a lot of those omega-3s, a lot of nice healthy add-ins to your diet, and then you don't have to worry about eating too much mercury. If you're a vegetarian, you're an exclusive fish eater, you might have to be a little bit more diligent about how much each serving is. And in terms of other things that we'll usually talk about, we'll ask you if you have any pets in the house, or our nurses do that kind of in our first history phone call. And that is partly to identify, are you someone who has a cat? Because cat feces is a transmissible way to get something called toxoplasmosis. And toxoplasmosis can have detrimental effects on the fetus. These are evidenced by ultrasound, usually in the 2nd or 3rd trimester. And so we just recommend that you don't do any changing of the litter box. It's not that you can't be around your cat or interacting with your cat, but we would just defer that to your partner or somebody else in your family. And then when you hear about avoiding like deli meat or hot dogs, unpasteurized, anything, cheeses, soft cheeses, dairy, or I always tell people apple cider in the fall as we kind of approach that. That is due to a concern for listeria, and listeria is a food-borne bacteria that sometimes you do hear about in the news that leads to food poisoning. And you're more susceptible to food poisoning in pregnancy, and this is just shown to be associated with poor pregnancy outcomes and sometimes stillbirth or miscarriage. So as much as you can avoid that, great. If you happen to eat it once, it's probably not a big deal.
On that too, all cheeses that, like, if you were to buy from somewhere in the United States, they do have to say if they're unpasteurized on it. So just like checking out your labels. And then with the cat too, if your cat is an indoor cat, you're less likely to have that exposure to toxoplasmosis because it's typically going to be from like a cat that's out hunting little creatures and eating bad meat from those creatures. So weight gain and rationale. We always talk about weight gain, and there is actually more rationale behind it than I think what people realize. It's typically going to be based on your beginning maternal weight. So we'll talk to you about weight gain at that first visit. And women that gain too little or too much weight in pregnancy do have increase in risks, and it goes in both ends of the spectrum. This can come up too with like past history related to nutrition, as I was saying before, like food is a huge emotional component for humans. And so like looking at, are women gaining too much weight or not gaining, is there a history of eating disorders? And is that something too that we can try to help work through in the pregnancy by working with our social workers or counseling or even nutritionists? So we want to watch for monitoring weight gain to look for cascading effects of excessive fetal growth or growth restriction. We know that when women are gaining too much weight, oftentimes we will see too that the baby may be gaining too much weight. And we want to make sure that babies are appropriately sized for the women that are birthing them. Also too, same direction in the opposite way, but if you maybe don't have access to food or you are unable to take in nutrition for whatever reason, there can be some growth restriction for babies. And so there's that stigma at both ends of that spectrum. In public, people will often comment, and I'm not sure why this happens, but even those comments like, wow, you're pregnant, you look so big, are you due tomorrow? Or you're so little. And I don't think most people do that to, make somebody feel bad, but I do hear often that women will feel bad if somebody's commenting on the size of their baby, whether it looks like they're too big or too little. So we will watch your weight at your visits. Sometimes we will talk about that, based on, is it not enough or is it too much? And then sometimes we'll do ultrasounds based on that too. We will always measure your uterus, and that can also be reflected by weight gain too. Like if your uterus is measuring too big or too small, that can be a reflection of too much weight gain or too little weight gain. Again, pregnancy is a window of opportunity to improve nutrition. So typical weight gain is going to be about 25 to 35 pounds. And this picture, I think, gives a nice breakdown of maybe where those pounds are going to be at. A couple of pounds to your breasts, 6 to 8 pounds to your baby, placenta, 1 to 2 pounds, your uterus, amniotic fluid, and then your blood actually increasing in volume, your protein and fat storage, and then your body fluids.
So another thing people ask me all the time is like, is there a weightlifting restriction in pregnancy, or what kind of exercise is safe for me? And so we love women who come to us with an exercise routine, and I advocate for you to continue that. So if you're someone who has been really active prior to pregnancy, I absolutely encourage you to continue doing that. And I want to reassure you that there is no specific recommendation for not lifting a certain weight, or in terms of, you might see things on the internet that are very conservative recommendations about like what your heart rate should be. But again, there is no studies that say that there is a threshold that clearly demonstrates a deficit or an impact to your baby if you're persistently crossing that. And so we do have a few caveats to which types of exercise we recommend. So any aerobic exercise is great. They have been well studied in pregnancy, kind of like the picture. The things that we want to avoid, I think, are actually on the next slide. So I'm going to say the benefits to exercise are amazing. That kind of does tie in with what Nicole was saying about weight gain. And so we know women who tend to exercise regularly throughout pregnancy do have decreased excess weight gain. They have a lower chance for having gestational diabetes, high blood pressure, or having a C-section. So in pregnancy, when you're thinking about what your baseline activity is, start there. And if you are super active, continue, great. If you aren't very active, we think that it's still beneficial to try for that 30 minutes about 5 times a week. And so we would encourage you to kind of start slow. We're not looking for any PRs. We're not looking for any, marathons to be ran during the pregnancy, but we love if you want to take up walking or any other aerobic exercise is absolutely safe for your pregnancy. There are kind of, like I mentioned, a couple things that are not recommended, and those are really because of the risk for potential harm. to your belly or falling. And so we don't do any like snowboarding, typically don't recommend skiing or water skiing. Horseback riding, again, it just depends on how likely are you to fall. No scuba diving. And then the American College of Obstetrics and Gynecologists say that you should be exercising in a thermoneutral environment. And so if your yoga class is 120 degrees, remember, we also tell you no hot tubs for the same reason. There is risk of adverse events to your baby if your body temperature increases like above 1 degree. So those are typically not ideal and also will get you extremely dehydrated. So definitely avoid that. And the other things that you would want to avoid or discontinue exercise for would be like severe belly pain, if you started to experience any vaginal bleeding, if you felt short of breath to the point where you felt like it was challenging to refill your lungs, those are reasons to stop. And it's all about how you feel that day. And if you crushed a workout one day and the next day it felt terrible, it's every single day feels different. And some days you're going to feel more motivated. Often after the first trimester, when your energy kind of rebounds a little bit, you're not as nauseous, you're able to eat calories again, but definitely jumping back into that exercise routine is healthier for you and your baby.
Yeah, learning to listen to your body and what it's telling you. Moving into vaccinations, prior to pregnancy, we would like women to have hepatitis A and B, HPV, MMR, varicella, flu, and COVID vaccine. During pregnancy, we would recommend the Tdap, flu, and then the COVID vaccine as well. And really the COVID is going to be at any point during the pregnancy as well as flu. There's some vaccines that we avoid, and that's just because they're not safe during pregnancy, but there is really no evidence that shows that these other vaccines are not safe during pregnancy. Tdap is typically going to be recommended between, I think, 27 and 36 weeks. Oftentimes women will say, well, you know, I had my Tdap updated last year, you know, and that's typically when you're going to get every 10 years. But what we know is that there can be passive immunity to the baby, which can help to protect your baby when your baby can't be vaccinated against whooping cough. Whooping cough is not something that is eradicated. There have been cases reported within the last 5 years, I think every year in Washtenaw County. I know that, I'm not certain about Wayne County. But so we do recommend these vaccines to protect women and your babies from developing an infection that could be life-threatening. With the COVID-19 vaccine and pregnancy, the biggest message is it is recommended during the pregnancy. You getting vaccinated is the best way to protect you and your baby from COVID-19. There are no safety concerns for you or the baby, and there's no evidence that COVID-19 vaccines increase risk of miscarriage or stillbirth. Pregnant people are at a higher risk of serious illness and complications from COVID-19 during pregnancy, and it's the same with the flu. There are protective antibodies that can pass from you to your baby after vaccination. It's also safe to get these vaccines while you're breastfeeding or while you're trying to become pregnant.
So part of the prenatal lab panel that we will check early on in pregnancy includes what your blood type is, and that is specifically to identify, are you someone who has a positive or negative blood type? And you might already know this from donating blood over the years. But why this matters when you're pregnant is in your first pregnancy, a baby is not going to be impacted at all. But if you are Rh negative blood type, your blood can identify antibodies on your baby or antigens, and then further down the road start to create antibodies that could attack future pregnancies' red blood cells. So I know this is a confusing topic, but depending on your blood type, let's say you're discordant from the FOB in your relationship, and then your baby has a different blood type from you. This is a really great demographic. So your first baby is, again, no impact, not an issue, but maybe if you get pregnant down the road, your body can attack baby's blood type and ultimately lead to miscarriage and stillbirth. And so we want to make sure after delivery and at any time you have bleeding throughout the pregnancy that we are giving you something called RhoGAM, and RhoGAM helps to block any recognition of those antigens so that your body doesn't make those immune fighter cells that could attack babies. And then during the pregnancy, we know that just like anybody else, we're susceptible to these upper respiratory illnesses. Constipation also super common, as the high levels of progesterone do slow down your gut. And allergies, you are certainly not immune to any of those things. So often women, we get lots of calls about, is this safe for me to take in pregnancy? And our office has a pregnancy guidebook. And so there is a list of these medications in there that are common and safe to take. So you don't have to feel guilty about continuing your allergy med. Those are older medications, are safe and well documented in pregnancy, as well as pretty much all the stool softeners. So anything that you've used to help combat constipation, or if you're someone who has IBS, that is okay to continue. Another thing that we deal with all the time as the pregnancy progresses, especially in the third trimester, is heartburn. And so many pregnant women have Tums right in their purse, but if we need to progress beyond that, it's also safe to use Pepcid. Tylenol is probably your number one go-to pain reliever. If you do have any issues, there's good safety profiles for Tylenol, despite what you may be reading in the lay press. And the things that we recommend you avoid are any NSAIDs. So nothing like aspirin, Motrin, ibuprofen, those are things to avoid. And there are a lot of other medications that are safe that aren't listed here. And so we just encourage you to reach out and ask us, because a lot of, again, the conservative things that you'll hear from other people are, no, you should avoid that. But if you double check with us, we are frequently making sure and looking up the safety profiles of these things so that you can get the treatment that you need.
As your pregnancy progresses, it often comes up usually in the second trimester, where around the 19-week visit to 23-week visit, sometimes women come in and they're like, I still haven't felt my baby move, you know, and I see and hear all these things about kick counts. Typically, depending on where your placenta's at, it may affect how soon or how late it is that you feel your baby's movements. Beginning after 28 weeks is when women can start to do like a true kick count. And if a woman is needing to do a kick count, we ask that you rest, sit, or lie down. And then you want to count how many times your baby moves. And you can do this for up to 2 hours, but what your goal is to get to 10 kicks. You might get to those 10 kicks in a few minutes and then you're done, and that's great. But sometimes it may take you that full 2 hours. Sometimes depending on activity level, like I said, where your placenta is, that can be challenging to, like, you know, gosh, did I feel my baby move today? It's going to be those times where, you know, you're used to how your baby moves and you're 32 weeks and all of a sudden maybe your baby's movements is not doing what it has normally done. That's when we're going to say, you need to stop what you're doing. We're going to have you do a kick count. We do have you come into the hospital if you do not feel those movements in that time period. I always like to let patients know too, you know, if you need to come into the hospital because your baby is not moving, that is very appropriate. We would never want anyone to feel bad about that, like, you know, needing to assess that. If you do call the provider though, they're probably going to say, here's what we want you to do. We want you to stop this. But sometimes people do come in just because they're nervous about that. Later in the third trimester, movements often do change. They don't decrease and they should never stop. But if you think about, you know, feeling movements of something in a space that's smaller, and you're going to feel all of those movements. But then, you know, your baby's growing and getting packed into your uterus, and then you're like, you know, and you're feeling this movement, maybe this movement. It's going to be different, but you still are going to get to know your baby in your uterus and feel those movements. So just keep that in mind, because that is actually
Yeah, it's more subtle, like rolls and turns and not so
Yeah.
aggressive kicks and punches, but that still should be 10 and 2 hours.
Yeah. Thinking about a birth plan can be a great way to like kind of stay on a healthy track for pregnancy. I usually talk with women at the beginning of third trimester if we already haven't had a talk about when to start to think about a birth plan. We know that discomfort and uncertainty can prompt seeking knowledge and information. And what we hope is that in planning for this, then it gives the opportunity to like decrease anxieties or fears, because we know that there is often fear surrounding preparing for labor and birth. And that can cause you to feel unhealthy, sometimes the stress of that. And so, if you're thinking about a birth plan, one of the easiest things you can do is navigate the internet. There's a ton of birth plans and you can just kind of read through and go, oh, I never thought about that. Or, oh, that really kind of lines up with what I think I would like, or I absolutely wouldn't like that at all. But just kind of thinking about those. If you don't have access to internet, you can do the old fashioned way, writing things down on paper and pencil. Here's what I know might be helpful for me when I feel afraid or nervous, or like you can't respond maybe because you're in so much discomfort. Here's what I like, here's what I don't like. And so that's probably the easiest way to start a birth plan. Birth plans are really like a blueprint, and they're a strategy, and they're preparation. Think about how you would envision your labor and your birth. And sometimes that's a scary thought to like actually think ahead to like, well, my due date's supposed to be July 13th, 2023. Am I going to have my baby on that day? Probably not.
We should have said that at the beginning. Think of it as your birth month, because only 5% of babies actually do come on that due date.
Yeah. And your blueprint, really, we want to know your personal preferences, your likes, your dislikes, and then maybe some culturally relevant birth practices. Something that I saw that was really beautiful, and I was very happy that a patient informed me about, was they wanted, when their baby came out and was born, they asked that the room be silent so that the father could whisper a prayer to the baby. And I thought that was great. It was also very hard to be quiet, but we did it. Nobody talked, and it was great. And we were able to like kind of meet that person's goal of that. So developing your birth plan, your strategy, your blueprint, you want to review it with your support team. It's good if you come up with this plan, but do the people that are going to be supporting you, are they aware of what's in that plan? So really going over that with them too, so they know what you want. I think it's hard if you don't like to be touched, and your partner all of a sudden is really trying to touch you and you're like, don't touch me. How do you respond to pain? Putting those things in there. And then bringing your birth plan either to your OB provider appointments, maybe bringing it and just kind of maybe asking, going over one or two things each visit, or just saying, hey, what do you think of this? Your provider, we're going to be able to give you some insight for feasibility. Sometimes, people will say, well, I know I want to labor in the tub the whole time, but I want an epidural. And those two don't actually line up with each other. So, we can kind of talk through like why that wouldn't really work out. We also can talk about sometimes like on the internet, you may see like, well, I know I want to do this, I want to do this, I want to do this. And then we'll say, well, that might not work because of A, B, and C. Maybe it's like the accommodations in the hospital. Maybe it's just, something that wouldn't work well. Maybe it's something that's actually not safe, and what the recommendation would be. So going over that with your partners, whoever's going to be your support person. If you have reached out to maybe get doula support, going over that with them too, just so that everybody knows. In our computer system, it's actually really nice too. You can take images of your birth plans and upload them, or we can do that for you when you come into your appointment. Sometimes one of the hardest things is working on a birth plan, and you have all these things in mind, and sometimes the best plans don't work out, but we're going to try to meet some of those things if things come up that we can't meet all of them. So always keep that in mind too. For your labor and delivery experience, sometimes people come in and they don't even know like maybe where they're going to go and have their baby, what hospital you're going to deliver at. So we'll talk to you about that. We'll let you know, like, how do you get a hold of us? What hospital do you plan to deliver at? This is the hospital where we're at. I always tell people, take a practice drive to the hospital so you know how far it is. And that way,
you know where the entrance is, so that just takes out that layer of anxiety.
right. And for your partner or your support
Yeah.
person, or like if you have like a, I mean, I think 23 was like shut down for a while, and it's like, okay, how do I figure out the back way to get to the hospital? So just thinking about like the labor and delivery experience portion of that, you want to have your bags packed for you and your support person and your baby. You actually don't need much, but sometimes I think just having some comforts from home can be very helpful. At your initial OB visit, we'll give you a book that's called like Pathways to Motherhood. And there's some great like packing advice in there. You don't have to overpack for sure. Like I think the days of that are mostly gone, but you don't have to bring 3 suitcases of things, just mostly your most comfortable things. Depending on where you're delivering at, you might be able to view an online tour of the planned place of birth. This can help decrease your anxieties about the birth, just so you can kind of see that space. I think with the pandemic that, we used to do tours at the hospital, and that is no longer an option at this time, but you can definitely see it online. We just wanted to include some things about stages of labor, as that can often increase your anxieties. And so one of the biggest questions that comes up like at the start of 3rd trimester is, how do I know when I'm in labor? Having a cervical exam is not always the best indicator. It can be helpful, but I just included too like pictures of what we're actually checking. If we're checking if somebody is dilated or is their cervix thinned out, just to kind of give you a perspective of what that is. And then the first stage of labor is going to be regular contractions that begin to dilate and thin the cervix. And then the beginning stage of labor is going to end when that cervix gets to being fully dilated. The second stage of labor begins at either complete or full dilation of the cervix, or if you're having a C-section, like as they're bringing the baby out, and it ends with the birth of the baby. And I have a picture of somebody pushing and then just delivery. And then the third stage of labor is the delivery of the baby actually, and then ends with delivery of the afterbirth and the placenta. And then there's the whole postpartum period that some people will call that 4th stage of labor. So I just put some images.
So things that we would absolutely want you to call for, and bleeding really at any point in the pregnancy, these are most common occurrences in the 1st and 3rd trimester, but heavy bleeding that necessitates you to wear a pad. We get calls often about women who just had sex or were doing something really strenuous. You had a little pink tinge with wiping. That's okay. That's not the kind of bleeding that's impacting your baby or your health. But if you're having heavy bleeding, either 1st or 3rd trimester, we would absolutely want you to call. We're always wondering about leakage of fluid, and so wondering if your water broke. So women experience this. Sometimes it is a waterfall like the movies, but often it's a little less subtle or more subtle, and we are kind of monitoring, is that slow leaking ongoing continuously through the vagina? If you wore a pad, would you soak through it? 3rd trimester, severe headaches that don't go away or visual changes can sometimes indicate preeclampsia, previously known as like toxemia. You might hear your parents or moms refer to. That is also something that requires emergent management. If you had a jelly-like mass that you palpated below the opening of the vagina, that would be something we would have you call 911 for. And then, like Nicole was saying, we are never disappointed that you came in for evaluation because you felt like the pattern of the baby's movements were different. We want to know that you're reliably able to get 10 kicks in 2 hours in the 3rd trimester. And so that is absolutely an emergency, and please come in and don't feel bad about it. So after you deliver your baby, you might be thinking about your family planning and how quickly you want to have another one, or you might not even be thinking about that at all. And both of those are completely natural responses. So just to kind of circle and close our discussion, it is recommended that you kind of have at least 18 months before becoming pregnant again. And sometimes you'll be breastfeeding during, a full year, and that kind of helps bridge some of that gap. But a true short interval pregnancy would be if you conceived within 6 months after your delivery. And those do have some increased rates of complications. So small babies and early babies, but hopefully you're so fixated and in love with the first one, you're breastfeeding and not even thinking about that. So for thinking about birth plans, we did want to just put some other resources that are out there in the community that we've heard patients have great experiences with. And so these, like Allison mentioned, will be in the resources provided, but these are some types of birth classes to help you get that experience that you're looking for, that do a deeper dive on all of the options that you're going to see on the birth plan and give you coping mechanisms and ways to manage and move through the stages of labor. And that is all we have.
Thank you.
Awesome. That had so much amazing information. And we do have a couple questions for both of you. So I'm going to kind of go back to the beginning and try to go in the order of your presentation. So I think I'm going to start with medications. There are a couple of questions about medications. So the first one is, this person has been taking 162 milligrams of aspirin daily since being COVID positive at 8 weeks pregnant. So it's recommended by their OB for the rest of pregnancy. So you mentioned no aspirin use preferred. Are there differing views, or is it okay that she continues to take this recommended dose?
I think I mentioned to Nicole, I was going to make a specific slide for aspirin, and I think it was in my notes. So yes, that sounds so crazy, especially after we say no NSAIDs, but the low dose aspirin has some very direct benefits in pregnancy. And so there are lots of reasons that we recommend starting that early in the first trimester. And so low dose aspirin, either 81 or 162 milligrams, has been shown to help your placenta create really strong blood vessel connections to minimize your risk for blood pressure problems later on in the pregnancy. And in COVID specifically, because COVID is an increased risk for you to have blood clots, it reduces your rate of blood clots. And so the aspirin that we're talking about for that is something you would take daily with your prenatal. It's not something for like analgesia or muscle aches or pains or anything like that. It's a much lower dose, and it's very well studied and safe. Great question.
Okay, excellent. So the next question is, for medications, should we be talking to doctors about dosage changes as weight changes? So if you take a medication every single day, should you be going back to your doctor, your specialist, to see about a dosage increase as you gain weight?
I've not heard that. So most of the time, it's not so much related to the weight that you gain during the pregnancy, but it's about volume of distribution of the medication. So because of some of the physiologic changes in pregnancy, so you have more rapid clearance of medications that are renally excreted because your kidneys are upregulated so much. And the medications that specifically come to mind for that are seizure medications. And then if you are on thyroid medication, same thing, your volume of distribution changes and your metabolism changes so much that those are things that we will check every trimester, or we might measure levels to help identify that you are still within the range and the treatment is appropriate. Most other medications don't necessitate different dosage changes related to the progression of the pregnancy.
Okay, perfect. So talking about genetic testing. So if you have someone who isn't pregnant yet, should this person and their husband have genetic testing before getting pregnant?
So this is something that would pertain to the carrier testing. So instead of testing, the baby during pregnancy, we would test you. Usually we start with the patient themselves, because if you look at carrier screening, I would absolutely encourage you to check your insurance, because it's very cumbersome and can be cost prohibitive. But yes, I think that we would recommend, if you either screen high risk based on your ethnicity, or you have a family member that you know, or you just want to make sure that the baby wouldn't be at risk for some of those common conditions, the carrier panels that we do have an option for cystic fibrosis, Tay-Sachs, spinal muscular atrophy, and sickle cell. Those are the 4 most common that we test, but there are also expanded carrier panels that test for like 32 things. And they get more expensive based on the number of things that you're testing. And then the more things that you test also increase your rate of a false positive. But you can absolutely talk to your provider before coming pregnant about doing that carrier screening on yourself.
Okay, excellent. So moving on to diet, we talked about eating the rainbow, but what if during your pregnancy you're really craving something that is unhealthy and super sugary and not what you should be eating? Do you guys have any suggestions of how to kind of like subdue those cravings without indulging in cookies and Slurpees and whatever else?
Yeah, I think again, like that goes back to some of the emotion of that too. And sometimes too, even based on a woman's BMI, there actually may be like true cravings related to that. I will often tell women, you know, if you know that you're like really wanting something, maybe try to cut it in half, have half that amount that you would, you know, if it's a piece of pie or a piece of cheesecake or a bowl of ice cream, maybe try to do half of that. And then just hydrating with water. You know, do you have a glass of water prior and then really think about it? Maybe give yourself some time and space to say, okay, do I still want that even after hydrating? Because typically, even with cravings, some of that can be subdued by just hydrating. Like often we're going to go for food when we're actually really thirsty.
And a short, like 5 to 10 minute walk can also subside some of those cravings.
Yeah, just releasing different hormones to kind of like
Mitigate that.
decrease that craving.
But we're not at all endorsing that you should never indulge those
No.
cravings.
Is fruit ever a substitute for something sweet?
Yes, absolutely. And
Right.
fruit is a great way to get in some nutrients and vitamins. Obviously, some fruits are really high in carbohydrates. And so watching that, especially if you're trying to watch your intake, but fruit can be a great substitute. Fruit's full of water too. Like most fruits are actually going to be mostly water.
Excellent. So how about fish? We talked about mercury levels and some of the fish, but is there a difference between farmed and wild caught? And then the other question is, and I'm sure if any of the participants are pregnant now, this is definitely relevant, but what about fish caught from the Great Lakes, like whitefish?
So all of the like fish mercury levels, I think the Michigan DNR actually has a great website too that goes over specifically like if you caught fish in this lake in this month, this is likely the mercury level. So looking at that, I mean, it's always going to be very specific to whatever type of fish that you're getting and where you're getting it from. And then as far as like farm raised and fresh caught fish, I mean, there's still going to be mercury levels. Yeah.
Yeah, I don't think there is. I know from a health benefit, you always want to choose one over the other, but I don't think that really the significance of the mercury levels changes very much despite the two.
Okay, yeah. Interesting. Okay, so if you're someone who's pregnant and you have several specialists that you see, so maybe it's like a psychiatrist or endocrinologist, rheumatologist, GI, what other appointments do you need to make in that first trimester other than your OB-GYN or your nurse midwife?
Oftentimes, like we're going to have a schedule of visits. Prenatal care hasn't changed a ton in the United States. We typically through ACOG and ACNM, we have these visits that in the first trimester, they're going to be about every 4 weeks. In starting at 28 weeks, we're going to typically say every 2 weeks you need to come in, and then at 36 weeks, once a week. And we follow you through in that time period because usually things are going to come up in the pregnancy more frequently as you become further pregnant. When we're looking at things like specific to like maybe you see an endocrinologist and they manage your thyroid medication, we'll often order those thyroid lab work and then have you follow up with that other specialty, depending on also how frequently they may want you to be seen with them.
Yeah, I would say, especially psychiatry, usually they're checking in at least once a trimester, and that also depends on have your medications been stable for a long time, or like I mentioned, with the volume of distribution changing, sometimes they'll just consult and then we'll order the labs for you. But I would say once a trimester is probably like a good, safe bet. Hopefully, if you're thinking about pregnancy, you had been previously talking to your subspecialist about optimizing your medications for pregnancy, but mood medications as well as seizure medications are actually quite liberal about how many that are considered safe for pregnancy.
So it sounds like your first stop should be your OB, and then they'll kind of direct you out from there.
Yeah.
Okay, perfect. So most people, well, maybe not, but a lot of people I think do have like an OB-GYN prior to getting pregnant. But I don't think many people have worked with a midwife before getting pregnant. So can you talk about like some of the differences between the two, and can a new mom work with both at the same time, or how does that work?
So nurse midwives are not really a new thing. It's just something that's probably become more acceptable in the last, probably I would say over the last 40 years. We're not physicians in the United States. Most midwives are first nurses and then trained with a specialty certification in nurse midwifery. So we're trained to take care of women in the antepartum, so like during prenatal care, and then the interpartum during your labor, and then postpartum, also doing like gynecology services from the time of like when a young lady maybe begins her menstrual cycle all the way through to menopause. If complications arise, we have our obstetrician teams that are what we often will kind of just say like, you know, my backup physician. And so if something comes up in a pregnancy that is not within our safety of care for you, we always consult with a physician. We have a dedicated obstetrician right now that we will talk about maybe higher risk things. For instance, if we're considering changing, you know, somebody from Zoloft to Prozac, or we may consult with like, there's some other teams of physicians that we may work with too. But we're usually going to be taking care of lower risk women. Because we're not physicians, we're trained in a different way. We have a different philosophy of care. We do a lot of shared decision making and just kind of like working with women with the goal. I mean, the obstetricians have the same goal too, but they're also, you know, surgeons and doing other things. But we want our population of mothers to be as healthy as possible, to then go out in the community and have healthy families, to then like affect the population of our, like the health of our population. So we don't actually, so like if you see the midwives, every hospital system is set up a little bit differently. Here we have a practice at Livonia that's going to be delivering at St. Mary's starting August 29th, and then at St. Joe's. So you would either choose to have care with a midwife, or you would choose to have care with the obstetricians. We help each other out. I mean, there's always going to be circumstances where maybe in the hospital, we're needing to help the obstetricians out, or we're needing to have them come in and help us out. So it's not that we would be caring for you together. You really make the choice independently of what type of care you want. But knowing too that it may come up that you see one or the other in labor.
Excellent. And so if somebody's interested in working with a midwife, would they inquire about that at their first OB appointment?
Yeah, so actually you can just call our office. Our reception and our nurses and our medical assistants are very well-versed in like kind of talking through that. There are some things that might risk a woman out of midwifery care. For instance, type 1 diabetes, we can't manage. And so we would, you know, we have kind of a list of different things, but that's an example of one patient where we would say, you know, it might better be served with physician management just because of the complications that can come up with that.
Okay,
We
excellent.
do have patients that are gestational diabetic and just diet controlled, and that's okay, but we usually find that out later in the pregnancy.
Okay, so no referral needed, and we will definitely include that contact information because we have several different practices in different locations. Okay, so as you're making your birth plan, what happens if your OB or your midwife just doesn't agree with something you want to do? Has that ever happened?
Yeah, this actually comes up a lot. So when there is that like birth plan, and that's why it's great to talk with your provider about, it's comes down to shared decision making. And so oftentimes if there's something that a patient is requesting, but either one just maybe doesn't make sense for the risk of that patient or for the baby at that time, we are going to try to educate you on why we're giving a recommendation for a different course in that plan. A good example of that is postpartum hemorrhage. We know that all women are at risk for postpartum hemorrhage. We know that there are some things that may increase a woman's risk of postpartum hemorrhage. There are some women that maybe, don't want to receive medication to manage bleeding after having a baby. But we know that that is the fastest way to stop a woman from bleeding postpartum. And we also know that for a woman to have a postpartum hemorrhage, that's actually going to affect more than just that moment or that birth plan. That's going to affect breastfeeding. That's going to affect mood, depression. Are you able to care for yourself and care for your family? So we try to educate patients in a way that's called shared decision making, and try to say, this is really why I recommend this right now. Or, we try to have permission, but sometimes there's also life-saving measures that
Take precedence.
yeah.
Okay, so we do have a couple of questions about the different hospitals. So what if my OB or my midwife doesn't deliver at the hospital I choose or that's closest to me? So maybe I see an OB in Ann Arbor, but I actually live in Livonia. How do I work through that?
So that's really going to be your decision when you choose your provider. So if you really want to go to a provider that provides care at the hospital you'd like to deliver at, that's really the best way to navigate that. It's really difficult for physicians and midwives to have privileges at multiple hospitals. It's actually safer to be with your obstetrician that's at your hospital or your midwife that's at the hospital that you want to deliver at.
Okay, so there was a question about, do OB and midwives deliver at multiple hospitals? So if you have an emergency and maybe you're closer to a hospital that your OB doesn't or your midwife doesn't deliver at, is it safer to go to the hospital where your physician is or your midwife is, or is it safer to go to the closest hospital and be with the on-call person?
So for a true emergency, it's safest to go to the closest hospital. And if you call the ambulance, they're going to take you to the closest hospital, and that's absolutely the right decision. I think, yes, there are some of us who do have privileges at multiple hospitals, but I think probably what wasn't explicitly stated is the model of care that we have sometimes is shared call coverage. And so if you are seeing a certain provider, that provider probably has several partners that they share the days that they are on call in the hospital or taking care of patients. And so we do everything that we can to try to accommodate delivering you on a day that we know that we're going to be there. But of course, labor being unpredictable as it is may not guarantee you to have that provider, and you might have one of their partners. And so we could talk about that. Usually we address that at the beginning of the care so that that expectation is well established.
Yeah.
Okay, and is it possible to see other providers in the practice so you kind of get to know multiple? That way you're not meeting a stranger necessarily in the heat of labor?
Yeah, yep, I encourage that. The increases your chances of getting a familiar face.
Awesome. Okay, so we have another question about the accommodations regarding the birthing environment. So referencing the birth plan checklist that you guys showed. So what is available in individual rooms at St. Joe's Hospital? And I'm going to assume that they're talking about Ann Arbor. And then COVID policies, are they still in place or have they changed? What are the restrictions in terms of delivery and labor options when it comes to COVID?
Okay, so the first part of the question was about,
The accommodations in the delivery room.
yeah, so all of the labor rooms have showers at St. Joe's. 2 of the rooms have tubs. The tubs are actually not for birthing in, they're for laboring in. There are balls, there are peanuts, there are eggs, there are bean bags. There's something called a cub, a CUB. The rooms, most of them are pretty spacious. There's a couple of them that are more for high risk, but sometimes if it is busy, then patients will go into those rooms. The showers are great. There's like a stoop and jets that you can put onto your back, or like kneel and they can kind of hit your belly if you want that too. For the C-section part of that, it says like a clear drape, and we do have those at St. Joe's also too, like if somebody is needing a C-section or planning a C-section. There's some nutrition, like throughout the night, nutrition's pretty limited. So that's why we'll tell people too to bring snacks in your bag, like non-perishable things or like fruit that's non-perishable. Yeah, I mean, it's pretty good space, and you can kind of, people do creative things in the space depending on what they want to. You know, people bring things from home, like
Bluetooth speakers,
Yeah.
if you want essential oils or incense,
Yeah.
that can also really help to personalize your experience.
yeah, Christmas lights just for like different lighting in the room can be really nice.
And the second part of the question was about COVID. So our COVID policies are that you can have 2 support people while you're in labor. So often that might be a doula and your partner. And we do test women who are coming in for labor for COVID, and your partner will just get screened at the door at this point. There is some discussion to continuing to relax that. I would say, most people are not laboring with a mask on. Once you have that negative result, we're pretty flexible about treating you like pre-COVID standards.
Excellent. Okay, so what happens if we have a birth plan in place and we get into labor and we want to change our mind? So something, we say, well, this isn't what I expected. I want to maybe alter that a little bit. Is that pretty easy to do? Or once it's kind of in your chart, are people going to be pretty flexible?
No, absolutely. I mean, that comes up all the time. You know, birth is just like raising kids, always something unexpected, always something new. And so, yeah, absolutely. Like, we're going to try to follow your lead too. You know, if you're like, I know I don't want to get up and walk around the room, but then all of a sudden you're walking around the room, great. Like, that's fine.
Awesome. Well, I think that wraps up our questions for this evening. I know you guys stayed on an extra 20 minutes to answer all of these questions. We appreciate that so much. Again, you will receive an email in the coming days, and it will have all of this great information, the slides, the recording, as well as contact for both Dr. Muszynski and Nicole Sekulich and the Nurse Midwives. So look for that to come again in the coming days. And thank you so much for joining us. And again, congratulations.